Much, Paul. I was just hearing the title that you were telling me about because I'm talking about difficulty getting the TOE probe down.
Exactly.
So,
Yeah.
yeah, okay. And hopefully I'll be able to talk for 20 minutes about that. Might be a little bit less. So really, I want to start off with the bottom line of this talk, which is we always must bear in mind first do no harm, which was came from Hippocrates, of course, and applies to pretty well everything that we do in our medical practice. And I think we'll come back to that at the end of covering a few of the options we have when putting the TOE probe down is difficult. And that will happen to you if you are a cardiac anaesthetist. It's happened to all of us. And we need to have a kind of process in mind for tackling the situation. And of course, there's all manner of complications that can come about from putting a TOE probe in, ranging from mild complications like sore throat, right up to severe complications, which are more rare, such as esophageal laceration, perforation. Those are the ones we're interested in because, of course, both of them can lead to death. So ACTAC in the UK published the results of a survey that they carried out in the UK, looking at over 22,000 patients. And they reported an incidence of major complication, being laceration or perforation, of about 1 in 1,300. And the really alarming thing about this is that the mortality for patients who've suffered one of these major complications is 40%, very, very high. And that puts the mortality after perioperative TOE from their survey at about 1 in 3,000. Now, there are several other large scale studies that have been published that put the mortality at slightly lower, sort of around 1 in 10,000. And I think it all comes down to in definitions and mode of data collection and so on. I suspect the truth is somewhere between the two. So complications from TOE, injury from inserting a TOE probe is something we need to be very aware of and take very seriously. When we're putting in a TOE probe, we all have our kind of favorite tricks. Most of us start off with the head in a sniffing the morning air position. I sometimes find if the probe won't go round the corners, the sort of first tricky area you can get to is where the probe goes through more or less a right angle bend from the mouth down to the esophagus. Sometimes if you flex the head on the neck, that can coax it into going down, always with very little force. And you know, it's a kind of natural thing that if there's an obstruction, you want to push your way past it. One of the reasons that I think we should all do echo all patients is that it gives you a sense of what normal feels like. And you can tell when the resistance to advancing the probe is abnormally high, and you can stop yourself from pushing too hard. Gently anti-flexing the probe tip before you put it in helps it go around that corner. Don't lock the probe tip in that position because obviously once the probe tip's gone beyond the pharynx and it's just going to go vertically down into the stomach. So you don't want it locked in a flex position while you're doing that. Some people swear by turning the head to the left or the right. I haven't found that particularly useful. Other people have said to me that once they've advanced the probe as far as the hypopharynx, they pause for a second or two before they then advance the probe further down into the esophagus, and they find that helpful. I have tried that. I'm not really sure about that. The one thing that I think makes a massive difference is jaw thrust. And, you know, after a while of inserting TOE probes with various tricks and tips in mind, I realized that actually the person who's doing the most work putting the TOE probe in is your assistant who is providing jaw thrust. It's not really what I'm doing. And in reality, in the UK, in the operating theatre, that's going to be our ODP. And our ODPs at Barts are fantastic at doing excellent jaw thrust. Unlike the picture in the slide, actually it's easier in the anaesthetic room if the assistant is putting their hands around the angle of the mandible from below rather than from above, as in the picture. There is a kind of variant on this. You can see my colleague Bruce Martin actually sort of producing the same movement, displacement of the mandible by putting his thumb into the patient's mouth and looping it over the inferior incisors and just pulling the mandible forward as he advances the probe. And you can see he's got a very gentle anti-flexion on the probe as he's putting it towards the patient's mouth. So if none of these tricks work for you, we're now moving on to thinking about what kit will help us. We at the Heart Hospital, before we moved into Barts, we started teaching all trainees to put the TOE probes in using a laryngoscope, because it straightens out that path from the patient's teeth to their esophagus, and also can help you by sort of pulling the ET tube out of the way. Follows on that you might use a video laryngoscope, but I've never actually seen anybody resorting to that. One thing that's really helpful if you have one to hand is having a pediatric probe. And the reason for that is obviously that they are smaller. So looking at sort of typical pediatric 4D probe. So these two in the slide would be appropriate for children down to about 5 kilograms. And the diameter of the probe tip is 11 millimeters. And you compare that to the diameter of a typical 4D adult probe, which is 16 to 17 millimeters. And actually that might just give you the advantage and give you the ability to put the probe down when you've been having trouble. Just thinking about the length of these probes, because you might imagine they're too short if they're pediatric. In fact, they're anywhere between 70 and 110 centimeters long. So it should give you the ability to do even some deep transgastric views if you want to. Finally, our last resort might be epicardial echo, which has been around for absolutely ages. And it's basically involves the surgeon putting a surface probe, so for all intents and purposes, a TTE probe, onto the surface of the heart in the open chest. And despite it having been around for a long time, it's actually not in the training curricula for either American or UK cardiac surgical trainees, as far as I've been able to find out. Despite that, the ASC published some guidelines for epicardial echo in 2007, and they described 7 views. They recommended that a practitioner carried out 25 studies, 5 of which had to be supervised by an expert before being allowed to make independent interpretations of the images. And I don't think there are any equivalent guidelines in the UK. But I think it's largely an institutional thing. If you have an enthusiast who's competent, they'll train trainees coming through. And of course, in children, pediatric practice, where just the size of the patient might mean that TOE is not possible, probably epicardial echo is going to be more commonly practiced. A lot of people have never seen epicardial echo being practiced as part of their anaesthetic practice, but I did find what I thought was a really good publication describing practical aspects of epicardial echo. Now, this article came from a group in India who stressed the point that actually, if you have low income or middle income countries where funding is constrained, you might find that epicardial echo is a more viable option than buying all the very expensive TOE probes and the training that goes with it. So as a group, they've been doing epicardial echo for decades, and they had a few handy tips to pass on. So these pictures are all from this publication. The top one's showing, obviously you need a sterile sheath to put the probe into, and the surgeon passes that over, the end of it over to the anaesthetist or echocardiographer, who clips it onto the drape that's on the barrier between the anaesthetist and the surgical field. And then what you do is you put a large blob of gel onto the probe, and put it into the sheath and slowly advance it within the sheath, making sure you don't touch anything going over the other side of the barrier. And when it's over the other side of the barrier, the surgeon can take hold and advance the probe transducer to the end of the sheath. Obviously, a small footprint probe is useful, particularly if you're doing peds. But the useful thing is that because you're putting the probe directly on the heart, a very high frequency probe will give you fantastic resolution images. So the recommended frequencies is 5 to 12 megahertz probe. So once the surgeons pulled the transducer to the end of the sheath, they can put a rubber band to secure it. We have rubber bands in our sheath kits. What they suggest, which I think is quite clever, is they cut off the wrist strip of a sterile glove and use that as an elastic band. They will squirt the sheath and probe with saline, plus or minus put saline into the pericardial space, just to displace air so that you can, that'll aid your image acquisition. The bottom picture is the anaesthetist's view of the open chest. So patient's left shoulder is here, right shoulder, it's moving slowly, is here. And just to point out the axis of the heart, is something that we become quite aware of when we're doing transthoracic echo. The long axis of the heart basically is oblique and passes down inferiorly and to the left, going towards the apex, going through the apex. And the short axis of the heart is obviously perpendicular to that. So this Indian group defined more views, and they tend to be more dynamic views, performing sweeps and tilts and so on, with the footprint of the probe in the same place. But what you can see from this list here is that the views approximate to some of the transthoracic views that we're used to. And in fact, if you think of it, it's in a way easier than transthoracic echo because you haven't got the pesky rib cage and sternum getting in the way. So you don't have to hunt for echo windows. The whole open chest is your window, and you can get some pretty good views. Of note, although I don't know if you saw on that list, there's a 4-chamber view, and this image on the right here is an epicardial 4-chamber view. If you're looking at the chest in the image on the left, you can understand that you can't actually get the probe to the true apex of the heart. So in fact, your 4-chamber view is acquired by imaging through the free wall of the RV. And you just need to be aware of constraints like that when you're interpreting the images, because your image interpretation is going to be a joint exercise between anaesthetist and surgeon. Other views, here's just another example, the epicardial long axis view, where you can see the index marker on the TTE probe is actually directed towards the patient's right shoulder. And the image that we're getting on the right-hand side there is not a million miles from a parasternal long axis view. So the images are very close to what we're used to. And in the absence of TOE, I think that epicardial imaging is a fantastic alternative option, although, of course, you do have to have the kit. So while you're thinking about what you're going to do, it's always important, particularly if you're just starting off in your cardiac anesthesia career, to call for senior help. when it's becoming obvious that things are being difficult. And with luck, a friendly face will appear. And it's always useful to have another pair of hands, another pair of eyes, and a brain to come up with some other ideas to help get the TOE probe down if you want to. I think it's worth, when things are obviously being difficult, it is worth letting the surgical team know in theatre what's going on, because before too long, a friendly surgical face will appear at the door of your anaesthetic room while you're going through a series of attempts to get the TOE probe in, and they'll be wondering how things are going. And the secret here is to not feel intimidated, because it's natural to feel a bit stressed that you're having trouble getting the probe down, because this is your opportunity to take part in a bit of shared decision making with the surgeon. So this is where your decision making process starts. You've tried all your tricks, you've thought of what's available, and you need to chat to the surgical team and the surgical consultant about what you're going to do about the situation. So I've made a little scheme of what I think my decision-making process would be. It's completely out of my head, so other people might have another idea. Is echo necessary for the planned procedure? And actually, if the surgeon and the anaesthetist agree that it's not necessary for the planned procedure, obviously you can carry on without TOE. Now, I actually have a policy of doing intraoperative TOE on all cardiac surgical patients, unless they have a raging contraindication. And the reason for that is that I think anaesthetists use intraoperative TOE as a hemodynamic monitor, not just as a structural assessment tool. And to me, although obviously we're talking about an invasive monitor as opposed to one that's not, saying, for example, that intraoperative TOE is not indicated in CABG patients who have good ventricular function is a little bit similar to saying, well, the patient's got normal respiratory function. If we haven't got a pulse oximeter, we're okay. I feel like my arm's being cut off if I don't have TOE in theatre. To me, it's an invaluable tool. So it's sort of, that's a discussion, not an argument, a discussion that's going to go on for a long time. I would say that, when you're thinking about whether echo is necessary, when I started as a consultant, virtually no patients had intraoperative echo. And we all seem to get through it okay. And as an enthusiast about echo, I'm the first to say, well, it's had massive impact on outcomes, etc. And so it's the best thing for all. But it is possible to perform a lot of cardiac surgical procedures without echo. And actually, the American Heart Association published a statement just this year, a couple of months ago, just with some of their thoughts about intraoperative TOE, because they were lamenting the fact that there hadn't been any sort of development or review of their guidelines since 2007. So one of the bits of information that they published was the increasing utilization of intraoperative TOE, getting their data from the absolutely massive STS adult cardiac surgery database. So just looking across time, the green bar is 2011, the blue 2017, and the red 2021. We can see that there's an incremental increase with each time frame. But what upsets me a bit is the fact that in 2021, still only 2/3 of CABG patients were receiving intraoperative TOE. So I'm surprised about it. I know, as I've said, there's this ongoing discussion about it. But it's a little bit perhaps disappointing to me. So if, however, you decide that in fact echo is necessary for your planned procedure, I think the next question to ask is epicardial echo an option? And obviously that's going to depend on the surgeon's experience and expertise. And if it is an option, you can proceed with epicardial echo if you feel the information you can get from it will satisfy what you need to know during the procedure. More commonly in the UK, I'm sure the answer will be no, epicardial echo is not an option. And then your final decision is going to be based on whether or not the procedure is urgent. If the procedure is urgent, you have no choice, really. You need to go on and do the procedure without echo. But as I just mentioned, actually, you can do most procedures without echo, particularly emergency procedures. I think, we can feel happy that we've considered all the alternatives if we reach that point in the decision-making algorithm. However, if the patient is not urgent, you've followed a decision-making path, which more or less means that you have to wake the patient up. And waking the patient up it does mean that you've got a chance to get more kit. For example, if you didn't have a pediatric probe, you can get hold of one, or you can find people with different expertise. You could find a surgeon who's happy to do some epicardial scanning, for example. But I suspect that actually in this situation where you've worked your way to the point where you're going to have to wake the patient up, that continued discussion and consideration might mean that the final decision is that echo is not necessary for the procedure. Maybe that's a little bit cynical, but I suspect that's the reality. So however you work your way through this decision-making algorithm, remember the bottom line: do no harm. Thank you.
Thank you very much, Sue. Your talks are always really kind of thought-provoking and excellent, and wish we had more of them. One question I was going to ask was, is there any benefit for anaesthetists to develop skills in epicardial echo, given that obviously it relies on having a second pair of hands to be able to join the surgeons on the scrub side of the drapes in theatre?
Yeah.
Or is it something that you would leave fully in the surgeon's domain?
No, I think, if it's something that your unit does regularly, you'd kind of expect it to be a surgeon anaesthetist procedure. But yeah, most of us do transthoracic as well as TOE. Most of us are used to the position of the imaging planes with transthoracic, and possibly, especially, if the surgeon's not terribly confident they'd be able to do it, I think it would be perfectly reasonable for an anaesthetist to scrub and put the probe in position to get the imaging planes. But you do, of course, need someone else at the machine end, because the machine's not sterile, to do the knobology for you. Yeah, no, I think that's perfectly reasonable.
Any other questions for Sue online? Do please raise your hand, put them in the chat, or just unmute yourself and ask away. One other question I had was, do you ever find that you kind of get the probe into the esophagus and really want a gradient across the aortic valve or something, and you can't get the transgastric view? Is there any kind of ways that you can fudge those sorts of measurements, or I suppose you get most of the information just from the kind of the 2D pictures?
Yeah, I mean, you can only measure the gradient with TOE from the stomach. Okay, so long ago, when I did a list where surgeons were commonly doing myectomies, the cardiologists would sometimes come to theatre to do the echo, and they would measure the gradient across the outflow tract in a mid-esophageal 5-chamber view, which I always thought was a bit weird. But the reason they did that was that when they were doing their TOEs in outpatients, patients didn't tolerate having the probe pushed down into their stomach. So they kind of felt that was okay. But in reality, you can only align your Doppler cursor with the flow
Yeah.
if you've got the probe in the stomach. So you've got a transgastric long axis view or a deep transgastric view. If you can't get either of them, and I think the other thing is we torture ourselves if we can't get a particular imaging plane. And the truth is that you can't always get all imaging planes in all patients. So you don't want to feel too bad about it if you really can't get the imaging plane. You can ask someone else to come and have a try, but epicardial imaging is a reasonable alternative if you think it really is an issue, because you can Doppler flow through the aortic valve from the aorta from above in the surgical field. Although I have seen a publication saying that you tend to measure higher gradients and higher velocities, higher gradients using epicardial scanning. Not quite sure why that is, but yeah. So if I can't measure a gradient across a prosthetic valve, I will discuss it with the surgeon and say, I can't get it, I can't measure it accurately.
Yeah.
Maybe I can't get a perfect view. Would you like to do epicardial scanning? Usually they say no. Most of the time, if they've been happy with the surgical procedure, they'd be happy for the assessment to be made post-op on the ICU.
And then there's one question from online too. Is there any role for kind of dynamic monitoring of diastolic dysfunction? So for patients with kind of known poor diastolic dysfunction, are you interested in the way that changes intra-op, I suppose, given our large hemodynamic changes?
Yeah, I mean, we know as soon as we give patients cardioplegia that their diastolic function is going to get worse. So, in a practical sense, it doesn't really make any difference to me and how I'm going to manage the patient. If I know they've got pre-existing diastolic dysfunction, I know it's going to be even worse when we come off bypass. And so I'm going to modify my support accordingly. So it's going to be, the phosphodiesterase inhibitors and so on.
Brilliant. Thank you so much, Sue. Appreciate your
Okay,
time, and I'm sorry we're overrunning.
no problem. I probably did too.
Oh, don't worry. It's my fault. I haven't learned after 5 years of booking these talks to how to keep to time. Never mind.